8. That's right here. 9. Okay, it's 1 o'clock, and looks like we got a quorum present. Clerk, call the roll.
Senator Butler?
Here.
Senator Elliott?
Here.
Senator Orr? Senator Allen? Senator Albritton? Senator Roberts?
Here.
Senator Bell?
Here.
Senator Kelly?
Here.
Senator Coleman Madison? Senator Marika Coleman?
Here.
Senator Stewart? We have a quorum.
Okay, quorum being present, we're ready to conduct business. There's a public hearing today. There are 5 people signed up to speak, 2 against the bill, 3 for it, and we'll go back and forth. First person I'll call is Colleen Lindgren. If you would state your name, and you have about 3 minutes to speak.
There. All right. Wonderful. Thank you, Mr. Chair, members of the committee. My name is Colleen Lindgren, and thank you for your time today. I'm here representing the Pacific Legal Foundation. We're a nonprofit public interest law firm with 17 Supreme Court wins on behalf of Americans' constitutional rights. And I'm here today in support of SB 236. Many believe that certificate of need laws are necessary to protect or improve rural healthcare options, but given the intended original purpose of certificate of need laws, it's hard to imagine how that could be true. In the 1970s, certificate of need laws were intended to limit the growth of new facilities in a misguided attempt to reduce federal healthcare spending. The federal government quickly reversed course. Unfortunately, not all states did. By their very nature, these laws discourage the development of new facilities, especially in rural areas. SB 236 recognizes this problem and exempts rural hospitals from existing certificate of need laws. 6 other states have some type of certificate of need exclusion or waivers for rural areas. These are Indiana, Montana, Ohio, Oregon, Tennessee, and Washington. Florida was similar before repealing almost all of their certificate of need laws a few years ago. These states exclude rural hospitals from those laws because they recognize that certificate of need laws do not prevent rural hospitals from closing. Just the opposite, they harm rural communities by discouraging new facilities from opening. And because we know that the process can take months, sometimes years, it is often not worth the time and expense to apply in the first place. As a result, patients are the ones that suffer. Alabama has had 7 rural hospital closures since 2005. In contrast, states like Colorado, Idaho, Utah, and Wyoming, which do not even have certificate of need laws, have had 0 rural hospital closures in that time. Research shows that repealing certificate of need laws doesn't hinder access to care, and that existing providers usually end up thriving. If they don't, it's because their services were not meeting needs in the community, not because there were too many options. Alabama already provides some relief for existing providers in rural areas, and this legislation expands on that practice to ensure better access to healthcare. Healthcare may be complex, but the principle of this bill is simple. Don't hinder potential healthcare services for rural Alabamans. Please support SB 236. Thank you for your time.
Thank you very much. I was a little out of order. I'm going to call on Senator Stutz to give us an introduction to his bill, Senate Bill 236, which removes the requirement for CON in rural areas. Senator Stutz.
Thank you, Mr. Chairman and members of the committee. What I'd like to do, with your permission, is just very briefly give you a little bit of history about the CON laws, and then after the public hearing is over, have a little summation statement, if that's okay with you.
Sure.
In 1946, after World War II, the Hill-Burton Act was passed to encourage development of rural hospitals. To receive funding, states were required to implement health policy planning programs. So in 1946, prior to this, only 5 states had any health policy planning programs. In 1972, Section 1122 of the Social Security Act required states to review capital expenditures, bed capacity changes, or substantial changes in services. Compliance with this act was encouraged by loss of Medicare and Medicaid funding if one did not comply. In 1974, the National Health Planning and Resource Development Act was designed to develop a national health planning policy to support cost containment efforts. This resulted in a majority of states repealing Section 1122 review and replacing it with CON laws. So the impetus to have CON laws dates back to 1974. In the 1980s, the National Health Planning and Resource Development Act of 1974 was repealed because it failed to reduce healthcare costs and was having a detrimental effect on local communities. Several states repealed or modified their laws in the 1980s. And prior to this, payments were made on a cost-plus basis, so facilities were paid at cost-plus, and there was a definite need to control proliferation of new facilities because if you just built a facility, you were guaranteed a cost-plus reimbursement for payment. And that situation no longer exists. So that's the historical background of how CON laws came into place and what changed in the 1980s to make them no longer necessary. And now, after we conclude the hearing, I want to have some other closing remarks with your permission.
Sure.
Okay, thank you.
We've had one person speak against the bill and for the bill, and now we'll have one against the bill. Joseph Marchant.
Thank you, Mr. Chairman. Thank you to the committee for allowing me to speak today. Certainly, I appreciate anyone who is considering anything to help rural healthcare providers, hospitals, nursing facilities. My name is, again, Joseph Marchant. I'm the president and CEO of Bibb Medical Center. We operate a rural hospital in Centerville, Alabama. We have a nursing facility there on that campus, as well as primary care clinics and a senior living community. I think, certainly just in seeing this bill come about, it was I'll just say concerning, alarming were the words as I started talking to colleagues around the state. Anytime there's not a represented provider that's promoting something for rural facilities, I think that's a concern, and I think that was something that I wanted to make sure I relayed today. We had a call as late as Monday about this, and not one rural facility, our constituency section that I represent with the Alabama Hospital Association, that's over 50 hospitals here in our state, rural hospitals from Alabama, that I think knows something about rural health care in our state. We understand our reimbursement. We understand the regulatory problems, our priorities that we have around our tables. Those things are workforce. Those things are reimbursement. Those are the challenges. I can assure you, CON reform in this way is not it. Just to eliminate something without having another plan or consideration of the good that is done anytime when you can control things. There is a finite amount of health care in rural communities. One of the many things I lose money on is an ambulance business, and I will tell you, it doesn't matter if it's ambulance, rural emergency hospitals, nursing facilities, there's a finite amount of health care in those communities, and when you're creating anything that creates redundancy or duplication, to say that that's going to have a benefit on quality, I think I would challenge you on that when I operate this thing every day the last 15 years in rural Alabama. So I just appreciate the opportunity today to speak on behalf of rural providers. I would ask you, just as you consider this, to consider where it's coming from. If your people in your district, your rural hospital operators, the guys that are struggling, the nursing facilities, the clinics, the physicians, if they're not the one bringing this to you, I would be concerned because, again, we are in rural Alabama every day, and we're trying to manage this as best we can. It's a difficult system, but not because of CON. That is not the challenge that's on my desk every day. So thank you for the opportunity to speak to you today.
Thank you, Mr. Marchant. Stephanie Smith. Stephanie Smith. There she comes.
Thank you, Mr. Chairman. Thank you, members of the committee. I'm Stephanie Smith. I represent the Alabama Policy Institute. The Alabama Policy Institute has promoted the curtailment of certificate of need requirements for a couple of decades now. If you'll remember, during the height of COVID, CON requirements were actually waived for about 5 months. And the reason for that was that the need was so great that the regulations shouldn't matter. And we're here to say that in the same vein, especially as it relates to rural hospitals, the need is so great that the regulation should respond to the need. A recent study has shown that more than a dozen of Alabama's rural hospitals are at risk of closing. As the previous speaker mentioned, that might not be because of certificate of need laws and regulations, but the lack of competition and the lack of ability for people to bring that competition to those areas might be. While in some cases the risk of closure may be due to population shifts, these regulations are contributing to the problem. States without these regulations have fewer hospital closures overall and fewer rural hospital closures. Our research shows that Colorado, Idaho, Utah, and Wyoming, who have no CON statutes whatsoever, have had 0 rural hospital closures in the last decade. Pennsylvania has also not experienced any rural hospital closures since repealing its CON laws in 2000. Since 2021, 28 states have enacted serious certificate of need reforms. These reforms lessen the burden of regulations on healthcare providers and increase access to care for citizens, and that is what healthcare should be about. There are 280,000 residents underserved just in the maternity area in the state of Alabama. 34.3% of our counties are actually designated as maternity care deserts. Birthing centers, standalone ERs, standalone surgery centers should be allowed to operate, especially in rural areas where the need is most. Thank you.
Dane Howard.
Thank you, Mr. Chairman. Dane Howard, Deputy Director of the Alabama Hospital Association. I want to start off by, again, thanking you for the opportunity to speak with you today and to reinforce what Mr. Marchant from Bibb County said. Not one provider operating in the state of Alabama thinks this is a good idea. We don't claim that our process is perfect, but it works for Alabama. There are actually some states who have repealed CON or have changed their CON, modified what they have had in the past, as you've just heard, and they did it and they kept it in place in rural areas for the very reasons that the proponents say it's needed. They kept it there because some of the outpatient surgery centers, ambulatory surgery centers, and other facilities that come in, they do not operate under the same requirements as hospitals, that you have to treat every patient that walks in the door regardless of the ability to pay. Some of the for-profit institutions that come in and build and compete with the rural hospitals only accept those with insurance. That accelerates the closure of the hospitals that are already struggling financially. Alabama significantly reformed our CON process in 2002 and made further modifications in 2012. We are not the least restrictive. That's the best word I can think of, and it depends on how you consider restriction. We are not the least restrictive. We are not the most restrictive in the nation of the 35 states who currently have CON in place. We're somewhere in the middle, but where we are is a place that works for the state of Alabama. And the providers who are subject to this, none of which are here in support of that bill. Thank you very much, and always available
Thank
for
you.
questions.
Brandon Farmer.
Thank you. My name is Brandon Farmer. I'm President and CEO of the Alabama Nursing Home Association. We represent 229 buildings here in the state. We're the only provider who has a location or a facility in every single county. We take care of roughly 54,000 residents annually, 24,000 to 25,000 on a daily basis, with a 31,000 to 33,000 full-time staff. That represents our footprint that encompasses a large portion, if not all, of rural Alabama. I want to speak just very briefly globally related to this bill. Obviously, we are in opposition to this, and the challenges facing rural healthcare cannot be solved through a repeal of the CON process. What Mr. Marchant said is exactly right. The challenges facing them, quite frankly, are very simple. Complex issues, but three simple things that they face. They face a market problem. Rural healthcare faces a staffing problem, and then they face a margin problem. And when I say margin problem, they face the ability for providers to come into that area and make a profit, whether they are a not-for-profit provider or a for-profit provider. Either way, they have to be able to make the bills monthly. And rural healthcare faces that challenge. And I think all of us here, all of you all, would like to see something done to help that, but the repeal of a CON process isn't going to do that because, quite frankly, it's not going to attract the providers into the rural markets. We're providers from out of state, private equity funded providers, hedge fund funded providers. They want to enter the state in the most profitable areas. Well, quite frankly, the rural healthcare markets are not the most profitable areas. That's why they're struggling. That's why us as the state are trying to address things. But the repeal of this process is, quite frankly, it's a complex, but it's going to have unintended consequences that reach far beyond just the impact in rural healthcare. And I mentioned staffing that Mr. Marchant and all providers face. In the next 5 years, according to the Alabama Board of Nurses, we're going to have a shortage of 14,000 nurses. So if we have an influx of out-of-state providers that come into these rural markets, if they even so choose to do so, where are they going to get the staff? We're already facing staffing problems that we all and you all through workforce development issues are trying to address through early college programs, through fostering the internships, apprenticeships, things of that nature that ultimately will have and play a positive role, but we're not there yet. So this is only going to potentially exacerbate a problem, and that's all dependent on anybody willing to come into the rural markets and do so. And again, I would echo what Dane said. You don't see providers up here advocating for the repeal of the CON process. Healthcare is not a free market process. You know, Mr. Marchant, he doesn't get to choose what he charges and what he has the patients pay. That's decided by third-party payors. That's decided by Medicaid, that's decided by Medicare. It's the same situation in nursing homes. So it could be extraordinarily detrimental to repeal something without looking at all the unintended consequences, quite frankly, for a system that works for Alabamians, that's designed to work for Alabama, and has proven over the years to do so. So I appreciate the opportunity, happy to answer any questions, and I would encourage you to vote no to this morning. Thank you.
Thank you. That ends the list of people that have asked to speak. Dr. Stutz, you want to summarize?
Yes, sir. Thank you. And I want to thank all the speakers that came to speak on this important issue. And what I would say in summary is I am one of those providers. I've practiced medicine in rural Alabama for 31 years. I served for, I think, 8 years on our local hospital board. So I've helped formulate hospital budgets. I know the process, but I also know how much money gets spent every year on CON applications, either fighting the application or applying for an application. And I look at healthcare in a simple way, that the only way we bring money into the healthcare system is by taking care of patients. And then you look at all the areas of staffing, capital improvements, all of the things that money goes out, and CON is on that list. There are millions of dollars a year that get spent in the state of Alabama either advocating for or against a certificate of need. And I simply say we need to apply some free market principles. But let me hit just a couple of other points, and I know time is short. The data doesn't support that the CON protects rural hospitals. In fact, there are several studies that show it's harmful. States with CON laws have 30% fewer rural hospitals per capita. It has the opposite effect. As was mentioned before, only 5 states in the last 10 years have had 0 rural hospital closures, and none of those 5 states have CON laws. CON does not protect rural hospitals, and the reasons that I gave in my presentation before about the history of it, the reasons for CON laws no longer exist, and they have not primarily existed since the 1980s. And there are 15 states in the last few years that have partially repealed their CON laws, and 12 of those 15 were total repeals. And the statement that Alabama is in the middle of the road and the most restrictive, or where we stand on that scale, there are 6 broad categories of what is required to be under the CON. And if you look at those 6 broad categories, Alabama is one of 8 states that has the most restrictive CON law in all those categories. And so what I would say in closing is that I appreciate the rural hospitals, that I've worked in one for 31 years. But when you hear from the nursing homes, the other hospitals, the things every one of those groups has in common is that they all already have a CON. So this is about stifling competition, and our job is to see that the services are available in communities and not pick winners and losers and restrict innovation. So I would appreciate your consideration and a favorable report on this issue.
Thank you, Dr. Stutz. Is there any, I'm sorry.
I'll be glad to answer any questions.
That's what I was about to do. Any questions from the committee? Senator Coleman.
Thank you so much, Mr. Chair. Dr. Stutz, I really would like to know the source that you're getting that information from, and then what are the other factors? Like, did these other states expand Medicaid? I want to know what the other factors are.
Yeah, and I am not in any way saying that's a 100% cause and effect, but it's certainly a correlation that's hard to ignore.
But it depends on the rest of the factors.
Right, there could be other factors. Like I said, I'm not 100% saying if you do away with CON, no more rural hospitals close, but I'm saying it is worthy to catch your attention that when we say it's a huge problem for rural hospital closures, and you look around the country and the only places that have not had any also don't have CON laws. And I understand that, you know, somebody mentioned Wyoming and was one of the states. I don't know what the others they said were, but you know, in the demographics of those states is not identical.
Exactly.
I understand.
Exactly. So just to, again, I would love to know the source.
Okay, I don't have that here with me.
Things,
I can.
I want to make sure that I have correct data to make my, you know, my informed decision on the vote that I'm going to take.
Yeah, and I don't have those sources here with me, but I can certainly get them for you.
Thank you. So this is my last question to you, because I really have a question for the API woman that spoke as well. But why did you not include the providers in the conversation? How come you didn't have a conversation with them or help them work with them to shape the legislation? How come you didn't include them? Because I'm going to tell you, for me personally, if I was being hit and nobody talked to me, I'd be pretty
I have
right
over the last several years, I've talked to several people about it, not before I filed this bill, but I knew they were against it, that they were totally against. I knew the Hospital Association was against it, that there's not a middle ground on, and I tried to strike a middle ground by saying, let's just look at it for rural hospitals, because that is the major issue in Alabama. But if you want to look at urban settings as well, you know, you look at Grandview Hospital in Birmingham, and that building sat vacant for 6 or 8 years during the transition. You know why? Because it was tied up in the CON process.
Doing a great filibuster right here, but I just still wanted to understand why not include those folks even in the draft, even if they're against.
Yeah.
And you know that.
Yeah.
But I think, like I said, if it was me personally and my business, my career field, and that's the question I really wanted to ask the woman from the Policy Institute, how would you feel if someone decided they knew better than you did about your own industry? That would be the question that I would have for her. You are a doctor, you say you're a provider, but I guess because maybe I'm a,
My point of that about the
like I know my wheelhouse and I like to listen to the experts that are actually doing this every day.
Yeah.
And so I guess that would be my question, but how in the world did somebody at the policy level that doesn't actually do the work feel as if
we
they
set
know better than
policies
the people that
affect
do it
their
every
work,
day?
though. And my point is that this is an unnecessary expenditure out of the healthcare dollar that does not serve the purpose it was originally intended to serve. I understand there was a place for it when you were reimbursed at cost plus, but now the healthcare dollar only gets split so many ways, and when you take part of the healthcare dollar and apply it to a restrictive policy, you're wasting part of that healthcare dollar that could be spent on staffing, could be spent on other things.
Close out with this, but the providers that are here are not saying that. They're not saying what you just said as it relates to the dollar. When I think about safety and protecting these patients, that is a cost.
Right.
That you have to pay. So the providers that are here are not saying what you're saying, and that just unnerves me a little bit.
Well, the certificate of need has nothing to do with patient safety or any of that. It has to do with who has the right to open a facility or offer a service. And
But what we were talking about, Senator, was the cost. You just mentioned a whole litany of things that cost the healthcare providers something. I was using those as two examples as well.
Right.
And so there is a cost to that. I'm just a little bit unnerved, though, that again, that there are folks kind of telling other folks.
And my position as somebody that has practiced medicine is I would rather see the dollars spent on those issues than I would on trying to overcome a regulatory hurdle. So.
Senator Elliott.
Dr. Stutz, and I think it's appropriate to call you Dr. Stutz right now because you know what you're talking about when it comes to this. You are easily one of the most principled people that I know in this body, and I respect you an awful lot for that. I have a question, and Mr. Farmer brought up a very valid point that I hadn't thought about until now as it relates to free market principles, which you and I think both share vehemently. But Mr. Farmer's point was that healthcare does not operate in a free market. They don't get to determine who their customers are. They do not get to determine what their reimbursement rates are. And in many cases, those hospitals don't get to determine whether or not they get paid for the services that they provide. And so that is very much not a free market, environment for those folks to operate in. And so I guess my only question, and again, I wasn't going to say anything until Mr. Farmer brought up this point, but if we're changing one side of this equation, I mean, ideally we would operate in a free market if the market dictated that there were services to be provided there and people would pay for their service, it would be purely free market. But if we change one side of this and we leave the other side, the fact that these folks don't get to pick their customers, they don't get to determine what their rates are, et cetera. How does that work? Does that question make sense?
It does. And, I'll tell you, there's kind of different sides to the answer to that. One is for elective things, community hospitals absolutely pick their customers, require their copay be paid up front. Probably once a month, twice a month, I try to schedule a patient for surgery who has a real high deductible on their insurance, and the hospital turns them down because it's not an emergency. And, till you pay your deductible, your $6,000 deductible up front or something, you can't be admitted non-emergently. So they do pick and choose on some things. I understand about the emergency room, but here's my point, and I understand healthcare is not a free market, totally a free market economy, and that, my fees are not what I charge, they're what the insurance company says they're going to pay for that. I understand that completely. But you look at another service, we'll say, I'm trying to think of something that correlates a little bit. We'll say auto body shops. Most of their work is paid for by insurance. Most of their work's paid for by third-party provide coverage, insurance, whatever. And my point is, the CON law is the equivalent of the state saying you can't build any more body shops in that county because there's already 2 body shops there or 3, and there's plenty of body shops. We don't need any more. We don't have cars that can't get fixed in that county, so you can't have any more. And then to make it worse, all the body shops in a 50-mile radius get together, and if you say you're going to build a new body shop, all the body shops in the 50-mile radius get together and say, we're going to fight you building a body shop, and we're going to take you to court to block you from building it. So my point of this, as far as free market principle, is competition makes everybody better. And provide good services. There's always going to be a need for good services. There's always going to be a need for good health care. And our job as legislators is not to control who provides it, but make it available to the citizens of the state of Alabama. And if eliminating some of the hurdles to having a birthing center in a rural county that doesn't offer obstetric services, whatever, you pick something in all the rural counties that have limited health care services and open up the free market for somebody to go in there and provide it. That's my point completely.
Senator Coleman Madison.
Thank you, Chairman. I kind of see both sides of it in a way. I understand, and some of the steps we might agree, maybe not for the same reason, but I do understand where you're coming from in the sense that there is a need. And we know that there is a need, especially in rural areas where people have to travel long distances. I'm still having to try to understand the full scope of certificate of need committees and what they do. And the thing of it is that, for instance, let's just take maternity wards or a birthing center, or even if you want to look at dentists, we have a very shortage of dentist office. And I'm just thinking that CON just dealt with hospitals and those kinds of things, nursing homes, but no, it's, and as you explained, no, it's any medical facility that might want to locate. So in that respect, and then of course, when we start talking to some of the big people in the industry, and I won't call any names, you know, how they argue one side. I said, but I don't see you all going into those areas. I know when I chaired health committee, and oftentimes we would have the larger groups that would come up and they would want to stop something from happening. And I said, but I don't see you all going into those areas to provide that service. You know, you don't want them to expand, but you are not going in to provide. And certainly maternity wards is one of those things, but you talk about the shortage in nurses. The last count that I had, this says probably in the next 5 years, I think it says it's going to be 15,000. And we are trying to do that through workforce development to provide those. But the other side has a point as well. And the gentleman that got up, and I don't know his name, but he made a very, very salient point when he talked about, I think it's like a three-legged stool in a sense, that in rural areas are really different in a sense because, you know, you don't have the market there, and not that there are not needs. You still have people there with the needs. But if I'm running a business, somebody coming into my store once or twice a week or once a month when the check comes is not going to be able to maintain. The other thing is that because of workforce shortage, we don't have the people to, and this is not something that's open on once a week, Saturday night special or whatever. It's got to be there open 24 or 7 days a week or 5 days a week or whatever, because there's a need. If it's hospital, it's 7 days a week, 24/7. You don't have that. You don't have that workforce out there. We are trying to get it, and that was another one. Even just cost of operating and everything else. So I would like to see, and I know it's not going to happen with your bill, but it really is a hybrid if you would look at it. But I think this is something that we probably do need to look at in the state and look at our Alabama as a whole and saying, okay, what is it that in these areas that we need, whether it's dentists or optometrists or birthing centers or whatever, and can we work together to try to say, in the next 5 or 10 years, that we want to try to establish these sites. It could be one center that houses all of that, but there is a need in the area that serves a particular region. We talked about this with the regional health centers that we talked about. I think it was that concept that never got off the ground. But I'm afraid to open it up and say, don't have certificate of needs, because everybody's just out looking at the bottom line or the dollar or an enterprise, a business that they can make. And nobody should be able to tell me that I can't go out and open up a business. And you've saturated the market. Everybody loses in a sense in that way.
But I can tell you an example that was shared from one of our colleagues yesterday with me. He lives in a rural community in North Alabama. They have a small community hospital. They have trouble getting patients for dialysis transferred to Huntsville. So they decided to start a dialysis unit in their small local hospital. They filed a CON, and the hospital in Huntsville contested their CON and blocked it.
That's why I say.
And that's why I'm saying the system does not work the way it's intended to work.
And
it's outlived its
there's
usefulness.
where I tend to agree with you on some of this, because I say that in looking at that, people should not have dialysis centers as those that we have. I mean, we have several in Birmingham, and using in a concentrated area. That is something that is needed throughout, and certainly.
Absolutely.
People have to, that's a daily kind of thing. If you've ever visited one, I mean, your kidney's working, you don't think about it. Right now, ours is working and we're not thinking about it. But for a person that's on dialysis, if you're not on that machine, your kidneys are not working. It's not cleaning the toxins from your body. But again, that's why I say we probably need to look at a hybrid kind of thing of what centers do we actually need and will work. And we know that we have a population there that will need that service without having to travel long distances. I don't think your bill is going to address that. But I do agree with you that we need to make some changes and probably need to review it and find out what we can do to find out what really works for Alabama. We get comfortable, we get like an old pair of shoes and we wear them and it's like the CON. It's been there all the time, it's working, why change it? We've
It's
changed.
worn out, just like the
Alabama has changed. Some of our needs, populations have shifted because of jobs and what have you, but we need to rethink and look at that again.
It's an outdated, political, corrupt process.
I don't know about that. You probably have a different relationship with them. I don't have any, I'm sure you do. But let's not throw the baby out with the bathwater,
That's why it's
Okay.
a limited repeal, but I'll be glad to answer any.
Any other questions from the committee? Is there a motion?
Mr. Chairman, I'd make a motion that we need to vote on this. I understand we're voting
Favorable
today.
by Senator Roberts. Is there a second? Second for Senator Orr. Roll call. Call the roll.
Senator Butler,
Aye.
Senator Elliott,
You have to skip me for a second, Kate.
okay, Senator Orr, Senator Allen, Senator Albrecht, Senator Roberts, Senator Bell, Senator Kelly, Senator Coben Madison, Senator Marika Tobin, Senator Robert Stewart. 5 noes and 3 yeas.
5 noes, 3 yeas, and the bill fails.
Thank you, Mr. Chairman and members of the committee.
Mr. Chairman, only thing I would say to the gentleman is maybe in the interim, if y'all can really get together and maybe truly try to study this issue. I've been doing a little research while I've been sitting here, so, I wasn't just in my phone. I was looking at other states and what folks have done, so maybe.
We could possibly have a study commission. The state of Georgia just did that during the last year. And I'll tell you, they studied it in depth. They came up with 9 recommendations. And
There's been
part of that is what's in this bill.
3.
So we did not draft the bill blind, I'll tell you.
We're, so statewide, we're occupied. Statewide, we're occupied.
Another regulatory